Now, this is a case example that I have seen in my clinic. The patient was an 84 years old woman who was diagnosed with type 2 diabetes more than 6 years ago. Besides diabetes, she also had hypertension, ischemic heart disease, Parkinson's disease, and diabetic nephropathy. She weighed only 47 kilograms and was thin and frail in appearance. She was referred to my clinic because she had occasional episodes of hypoglycemia in the afternoon, with blood glucose down to around 30 to 40 milligrams per deciliter. However, her fasting glucose has been mostly within 110 to 120 milligrams per deciliter. Her food intake was irregular and her appetite sometimes poor. Her hemoglobin A1C was 6.7%, which may be good for a typical adult diabetic patient, but is actually a bit low for an elderly patient like her. Her cholesterol level is only modestly elevated, and she had acceptable renal function. Her diabetes medications included glimepiride, which is a sulfonylurea, metformin, sitagliptin, which is a DPP-4 inhibitor, and a basal insulin glargine, which she injected at bedtime. So after reviewing her medications, I discontinued her glimepiride, which is an insulin secretagogue and the most likely culprit to cause her afternoon hypoglycemia. Whereas metformin and vildagliptin were continued, since these two drugs are much less likely to cause hypoglycemia. I also reduced the insulin dosage from 20 to 16 units and changed the time of injection from bedtime to morning in order to reduce the risk of nocturnal hypoglycemia. After the adjustments in medication, the patient's blood glucose had been kept within 100 to 200 milligrams per deciliter. The hemoglobin A1C had risen to 7.2%, which is still very acceptable for an elderly patient like her. And most importantly, she had no more hypoglycemic episode. The second case was a 90-year-old woman with type 2 diabetes since about 20 years ago. She also had stage 4 chronic kidney disease, hypercholesterolemia, bronchiectasis, osteoarthritis, and a recent humeral fracture. Her fasting blood glucose had been within the target range of 90 to 130 milligrams per deciliter. However, she would sometimes have hypoglycemic episodes with glucose level down to below 80 milligrams per deciliter in the afternoon. She had good food intake and was reasonably well nourished. Her most hemoglobin A1C was 7%, which may be fine for younger adult patients, but may be too low for an elderly patient like her with risks of hypoglycemia. Her lipids were well controlled, but she had poor renal function with an eGFR of only 22.4. Her medications included twice daily injections of a pre-mixed insulin, Humalog Mix 50, which contains 50% of rapid-acting insulin lispro and 50% intermediate-acting lispro-protamine. She was also taking atorvastatin for control of her cholesterol level. And so, considering her risk of hypoglycemia with a premixed insulin, I substituted her Humalog with once daily injection of a basal insulin, which was insulin degludec at 25 units each morning. That was about 70% of the total Humalog dose she was using previously. I did not consider the use of oral anti-diabetic agents because her renal function was poor, and I wanted to keep her treatment regimen as simple as possible. After the adjustments in medication, her blood glucose became more elevated. Her hemoglobin A1C had risen to 7.5%, which was still very acceptable for a patient of her age and condition. Moreover, she had no more hypoglycemic episodes afterwards. Next, I will consider stopping her atorvastatin, since at her age, it probably has very little benefit in terms of cardiovascular risk prevention. And so these cases illustrate that for elderly patients with hypoglycemic risk, diabetes medications should be simplified and de-intensified whenever possible, especially if the patient is using insulin or insulin secretagogues. And a less stringent glycemic target should be set that are appropriate for their age and condition.